Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
Disclosures for this podcast are listed on the podcast page. Hello and welcome to this two-part episode of the ASCO Education Podcast. Today we will explore some real-time and real-world issues that oncologists face while practicing in rural areas in the U.S. and abroad. Cities tend to benefit from having more doctors, facilities, and equipment to address the health needs of the population. In contrast, people who live in rural areas, estimated to be about 25% of the U.S. population, face various challenges to obtaining consistent health care, including scarce medical personnel and infrastructure, and transportation of that care may involve considerable time and financial expense. I'm Dr. Jack Hensold, a hematologist oncologist in Bozeman, Montana, and chair of the ASCO Rural Cancer Care Task Force. I also serve as medical director of regional outreach at Bozeman Health. Joining me is Chris Prakash, oncologist and medical director of Texas Oncologists and president of the Texas Society of Clinical Oncology. Chris is also the director of quality services for the statewide group and leads Texas Oncologist Precision Medicine Initiative. Also joining me is Professor Sabe Sabesan, a medical oncologist in regional Australia. He is the president-elect of the Clinical Oncology Society of Australia and clinical director of the Australian Teledyne Health Program, led by the Queensland State Department of Health. Professor Sabesan is an internationally recognized expert in the area of teleoncology. He has developed and evaluated various oncology models to deliver cancer care closer to home. Providing healthcare is a very involved career, more so in rural areas. Dr. Prakash, you've finished your oncology training in Detroit, yet you practice primarily in rural Texas. Can you detail the factors that led to your decision in practicing oncology in a rural setting?
Thank you, Jack, for having me as part of this podcast. I finished my fellowship at Wayne State in Detroit, Michigan, and we were looking for a place to raise our kids and family and to find a good practice for myself. My daughter was 2 years old at that time. We were looking for a quiet, safe place with a laid-back lifestyle, but at the same time, a dynamic oncology practice. That's how I found East Texas, which is primarily a rural area. The small community here, good schools, and nice, accepting people really appealed to us. So we decided to give it a chance. We're still here almost 23 years later. My daughter has grown up and is in medical school. And my son, who was born in Paris, Texas, is planning to go to med school next year. Over the last couple of decades, I've found that practicing oncology in a rural setting is indeed very rewarding. You can make a difference in people's lives here. People are simple, they have faith, and respect and follow doctors' advice. Practicing here, I've had a real chance to make a difference in not only people's lives, but also in the overall healthcare system and in health policy. As you know, Jack, about 18 to 20% of the population lives in rural areas in the U.S., but only 3% oncologists are available to provide care for them. So I'm not only fulfilling a need, but also satisfying a desire to contribute.
Chris, could you clarify the nature of your practice? Are you a solo oncologist within a much larger group spread out over the state, or is there more than one oncologist in your site?
Yeah, so I'm part of Texas Oncology, which is a statewide large group with multiple sites of service. In my location, there are 3 medical oncologists and 1 radiation oncologist. So we serve the catchment area of Northeast Texas and Southeast Oklahoma. But within Texas Oncology, we have locations spread out all over the state.
Thank you for that clarity. Professor Sabesan, you started in Sri Lanka and are now in a rural area of Australia. How did that happen?
I grew up in northern Sri Lanka in a village, but moved to Australia because of the war in Sri Lanka in 90. So I did my med school in Adelaide in Australia. During my med school, we had to do a lot of rural clinical placements. And also as a result of that, I did my internship in a central Australian town called Alice Springs. Throughout that journey, I saw firsthand the difficulties these communities face in accessing healthcare, basic healthcare. So when I finished my training in medical oncology, I was looking for a place where I could contribute to minimizing these difficulties, but also taking an academic angle to this. So I chose a regional center called Townsville in North Queensland as our home that actually serves a large rural and indigenous populations, but also it is an academic hub for rural medicine. So it kind of served my clinical and academic needs. And we've been there last 20 years now.
A significant hurdle for patients in rural areas is transportation. Patients sometimes travel an entire day or stay overnight near the clinic where they will be examined or treated. What resources have been developed to assist with transportation and help patients come back for test results, appointments, and treatments? Chris?
Transportation, that's a big hurdle for many patients across the country, but mainly for rural population. So as I just said, my practice is in Paris, Texas, but the draw is about 250,000. So patients come to see us here to receive their medical care from all over Northeast Texas as well as Southeast Oklahoma. And there is no public transportation in many of these areas. The average time to commute for many of my patients is in excess of hour and a half each way. Patients do travel sometimes an entire day. They sometimes have to stay overnight to receive their treatments the next day. I recall a patient with tonsillar cancer last year who was receiving concurrent chemotherapy and radiation. So he lived almost 3 hours away. This was too cost prohibitive for him to travel back and forth on a daily basis for radiation therapy. So what he did was set up his camper right behind the cancer center, which certainly made it a lot easier for him to get his treatments that way. I would not recommend that as a routine practice for everybody, but it did work out for him. Close by, there is a community of Choctaw Indians here in Southeast Oklahoma also, and they do have some options for transportations for just their citizens. And locally, some local church groups and volunteer organizations provide assistance with transportation for some patients as well. But that is a problem. Transportation is a big access issue for my population.
Thank you. And just to make a comment, there's actually a fair amount of literature regarding what we refer to as financial toxicity associated with the need to travel. Sabe, do you have some transportation problems in your area, I would assume?
This is similar to what Chris and you are describing, Jack. Our area is 2,000 by 1,000 kilometer with about 650,000 population. There are scattered rural hospitals, but really there's no consistent public transport. But the government does pay for transport and accommodation. I heard that it doesn't fully cover it. But one of the disappointing things is that if you're traveling for clinical trials, that subsidy is not there for them. So that's probably one of the reasons why the governments have gone for the telehealth investment.
Thank you. Telehealth is a critical tool for providing healthcare in many areas, including rural areas. How do you manage the health literacy problems of ethnically, educationally, and socioeconomically diverse populations using telehealth? Chris?
Telehealth, as you know, has been around for a long time, but during the pandemic, that's when we needed to keep our patients safe and away in their homes and still continue to give healthcare to them. So we conducted many visits through telemedicine at that time. Telehealth is especially useful for many patients in rural areas, right? Because they have problems with access. But there are many challenges. As you know, there is a broadband divide in the US. About 1 in 4 Americans do not have a good broadband connection. So it is very difficult for them to perform a video telehealth visit. Audio works out okay a lot of times, but to do a good video telehealth visit, that's a difficulty. Also, as you know, many of the flexibilities that we were afforded during the pandemic regarding telemedicine, they are slowly going away. So that's making telemedicine even more difficult to do. But yeah, telemedicine is a boon for many of the patients who live in rural areas. I remember just the other day, I saw an elderly couple. The man had just been diagnosed with advanced lung cancer. In the room, he requested that his children join the conversation via FaceTime on his phone. so that they could listen in on what I had to say and what I had to tell them. This was indeed very helpful for them. I was able to explain to the patient, his wife, as well as his children who joined via FaceTime about the diagnosis, which was new, the treatment plan, expectations, moving forward, and all of that. So even though this was not a true televisit, it really demonstrates how technology can help us deliver good communication and good oncology care in many situations. But still, I would say that for many patients, telemedicine is not ideal. It's especially true given the devastating diagnosis of cancer. Patients want to see their doctor face to face. As a doctor, I want to examine them. And also, body language is very important. It is important for my patients to trust me as a physician. And that's hard to do sometimes via a video chat. So right now, my nurse practitioners do a lot of chemo teaching through telemedicine. Now that is really helpful for them because this can be done over multiple teaching sessions. It makes it a lot easier for the patient because rather than coming into the clinic for all these visits, they can learn from the comfort of their homes before they really start the toxic chemotherapy.
Chris, thank you for that. I think that you make a very valid point, and one that I've made, which is that telehealth is a great tool for overcoming geographic barriers in rural areas. But I think we just simply have to accept the fact that it's not as good as a face-to-face visit. So how we blend the use of telehealth with face-to-face visits, I think is going to be a challenge moving forward.
Yeah, I totally agree. I think, toxicity management is great. I mean, it's a great tool to call and see, how patients are doing after treatment. But that initial visit, there's something to be said about establishing a rapport and faith and trust in your doctor, when you're treating cancer.
I completely agree. Sabe, you sound like you're one of the experts in Australia regarding telehealth. I wonder if you have some comments about your experience.
Yeah, I would say it's an evolving experience which has evolved over, 15 years. So in terms of the health literacy needs, my observation is it's actually the same whether it's in person or in telehealth. What we observed is that we just need to tailor to the patient's needs. When we first developed the telemedicine, we had the same issues, developing rapport and seeing first consultations in person. But what we did, we started doing a lot of shared care models and telesupervision models with rural facilities rather than directly into homes. So what that meant, we had patients' families can attend, especially the primary care physicians and the rural nurses were able to sit in with the patients. So that means if there were any communication issues or any translation aspects, language-wise or explaining medical lingo, there was a system in place in rural sector that is close to home that was provided by the primary care physicians and the families. And also then from that experience, we did some research and the patients actually said they were happy to continue initial consultations on a telehealth consultation provided there were families involved, the primary care physicians were in there, and also the Aboriginal health workers. So for some regions, now we do the initial consultation purely on telehealth. Because what telehealth does for the first consultations, if we need to then bring them to our center, then we would be able to coordinate the whole trip rather than coming and back and forth. So that's actually probably the difference in a couple of the largest centers. But the other main benefit I actually found for indigenous patients is that we can involve the whole family in the patient care. And normally that means they are able to ensure compliance and compliance with clinic visits. So it's been evolving, but really it is what our models are. Some of them are teleoncology replacing face-to-face. Some of them are hybrid. Some of them are treatment related. So it's really based on the needs of that little communities. That's what we've been doing.
If I can ask a question, Sabe, on that, do you experience barriers to practice across state boundaries in Australia? Because I know in the US, that's a big issue. That's a hurdle. Licensing is an issue across, state boundaries. And also broadband issue, because a lot of my patients, they simply don't have the broadband width to get on a video chat. And do you experience that in Australia as well?
So we definitely have the broadband divide in Australia, but luckily the state governments have actually invested heavily on fiber. So all the health facilities, whether they are small or large, they are all connected on fiber. So if you do video calls or telehealth within that system, it is pretty good. But as soon as you go outside to a primary care facility that is not part of a state facility or home, you run into trouble with broadband. But in terms of the state boundaries, I think it is a bit loose. I don't know whether there's actually a strict monitoring of the systems, but because the whole Australian system is funded by Medicare, it really doesn't matter where the patient is as long as you build the patient based on the consultation.
So, and I'd like to just respond to something you said, Sabe, too, which is the involvement of primary care doctors and local healthcare workers in the care of patients is something I will return to later in this conversation. But I think it's important that we consider when we're keeping patients out of our larger centers and treating them in their own home areas, that we are relying on supportive care by those primary care providers. Any other comments regarding the telehealth issue?
In terms of the primary care, shared care models and collaborations, that is actually one of the important aspects of telehealth because we have in rural sector, the turnover of the staff is pretty high. So then what happens if we want to provide consistent medical service on telehealth, something needs to be consistent. So we become the consistent aspect of the partnership. So then that gives us a bit more safety that there's a shared care model. But also what we found now that in terms of educating on oncology topics, the shared care models actually give you opportunity for case-based discussions. I think there is a benefit for workforce development as well as connecting the rural workforce with a network of workforce.
Involving primary care physicians in the total care of the patient is vital, especially in rural areas, because they really depend upon their PCPs, and often these are APPs providing their primary care. You got to manage their diabetes and hypertension and go through all their medications, antiemetics, pain medications, work with the local pharmacy. There's so many issues that go into treating a patient with cancer. And as an oncologist sitting 100 miles away, I'm not going to be able to take care of every detailed aspect of their care. So what I do is involve their primary physician from the very beginning. So when the patient first comes to me, it could be via telemedicine or not, I'm calling them back and saying, hey, I saw so-and-so, this is my diagnosis, this is my plan. I'm going to do all the treatments here at my center. But whatever's possible you can do locally, I would appreciate that. If there's labs that can be drawn, imaging that can be done locally, any testing that can be done locally, patients really value that because they don't want to travel 2 hours just for a CT scan if they can avoid it. That's my practice.
Thank you. You mentioned something that we're going to touch on next, which is that in rural areas, it is often difficult to access labs, imaging facilities, and other specialized treatments, certainly CAR T therapy and other highly technical therapies. There are other services that may be limited in a rural area, such as mental health, fertility preservation, palliative care, access to social workers. Do you have solutions to address that really supportive care and those needs?
Yeah, I think, Jack, you touched on a very, very critical challenge right now. It's a workforce issue. It's very hard to hire and keep good ancillary support staff, not only in rural areas, but all over the country right now. So you mentioned social workers, nurses, nutrition specialists, mental health providers, even fertility services. They're very hard to find in rural areas. There's a big workforce problem, right, all over the country. But the pandemic really exacerbated that. I mean, it's hard to find good staff anywhere. And there's no easy solution to fix this problem. So what we need to look for is maybe provide incentives, such as loan forgiveness programs or tuition payment programs or repayment, really anything that keeps professionals in rural settings. And we need to find people who like working in these areas because that's a very difficult problem as well. And as you know, many specialized treatments, stem cell transplants, CAR T cell therapy, specialized neurosurgeries or cardiothoracic surgeries or many oncologic surgeries, they can only be done at big tertiary centers in big cities often, right? So patients got to travel a few hours to go there. So what we can do to make it easier on them is provide the first consultations with those specialists via telemedicine. And if they're thought to be good candidate for the procedures, then they can make a trip that's necessary to the city, let's say. But also you mentioned consistency, right? That is the key. It's very important to be consistent if you want to provide quality cancer care. It could be imaging, it could be diagnostics, molecular testing, or any kind of therapies that you deliver. They should all be consistent no matter where a patient is being treated. So that brings into question provider education. Many oncologists in rural areas, they're generalists. They treat all cancers. They do not specialize in one area. It's really hard to keep up with all the latest information that's coming out. So it's important that we provide all educational tools possible to keep them up to date. I just moderated a meeting called Oncology Congress. So this is geared towards cancer care providers in rural areas. It's a free CME webcast, various topics on cancer, excellent faculty. And the main thing is that the discussion is geared towards improving multidisciplinary care in those rural settings. So I think another thing that we could think of as a solution to this problem is virtual tumor boards. I mean, they're very helpful where somebody can get on and get an opinion regarding a difficult case. But I think most helpful is if you have a network of doctors or specialists that you can rely on. You can call somebody, a quick consult, or say, hey, I have a problem, a challenging case. What would you recommend? Because sometimes we just don't have time to wait for that tumor board or wait for, an official consultation. So yeah, it's a difficult challenge.
Yes. And again, a point that you made that I'd like to respond to is the virtual tumor boards and the basically shared education with maybe a larger group. As we've kind of in Montana looked at kind of a development of hub and spoke models, we've realized it may make sense to consider a hub and spoke communicating with a spoke and hub. In other words, a larger center with what becomes the hub for a smaller community, and then that reaches out. So there's a series of educational connections that need to be made.
Yeah, I think you almost need multiple hubs, right? So one central big hub, in this day and age is probably not going to help solve that problem. So you got to have a big hub, and then maybe a series of regional hubs, where patients can easily access and doctors can access information.
Yes, I think that's absolutely correct. And the education piece too is, I think, something that keeps oncology practitioners out of smaller communities where they may be practicing by themselves, because it's difficult, as you know, as an oncologist, to feel like you're staying current with everything you need to stay up to date with, and therefore practicing in a larger group where you can turn to someone else for some immediate education.
That's very true. And if you really look at, what these CME programs or educational programs are geared to, none of them geared towards rural practice. They talk about, big clinical trials, and those populations are really not my patient population for sure. So you really need a program where people who know rural medicine, who have experienced it firsthand, like you, me, and Sabe, and say, okay, this is what really happens. You cannot give CAR T therapy to every lymphoma that walks in, right? So I think those are the kind of education we're talking about. There's so many educational programs that are available, but not many for rural practitioners.
Right. And it does speak to whether or not we need to be thinking about developing some type of education that's easily accessible to those very busy practitioners who may be a solo practitioner with no one around for hundreds of miles.
Yes, and not to throw in a plug for my conference, but the Oncology Congress that I do twice a year, that's the sole purpose. We will have faculty from big centers, but I make sure that the conversation moves towards rural settings where we do not have all the latest technologies and the therapies available. And we had a really good turnout this past weekend. So I'm happy to share, information if anybody's interested.
Yes, that would be great. Again, I think this conversation has been terrific, because I've really become focused on the issue of the inadequate education we have, not only for our oncologists who are out in practice in smaller areas, but also for the primary care providers who need a better understanding of what's required for supportive care of oncology patients. And there's very limited material that focuses on that as well.
Totally agree. Just one last point I want to make is, with the checkpoint inhibitors, that's a perfect example. Many of these toxicities are multi-organ, and the patients in the community, the docs in the community, sometimes are not aware of if the skin rash or lung symptoms or pneumonia is really related to the therapy. So very important to involve the whole team in their care.
Completely agree. Sabe, what about your experience in this regard?
Exactly the similar experience Chris been describing. Another group of rural people, that is actually smaller rural communities. Sometimes they're like 500 or 1,000 population maximum. So those kind of places, they completely miss out because they're too small for even for standard general medicine specialties. What we've been observing over time or focusing on is really how do we build those capabilities at rural sites? Because if they keep doing the same stuff, then they are not going to grow or build. So what we've been doing, let's build some rural capabilities and let's also focus on expanding scope of practice. So to do that, we actually have to start shifting specialist services like chemotherapy administration or rheumatology infusions back to those smaller towns. And then we have to utilize telesupervision and shared care models with allied health and the rural health workforce. So when that happens, we need more staff because there are more activities happening. And what we found in a western Queensland town of Mount Isa, before 2007, maybe few chemotherapy, and patients had to travel for everything. Over time, we shifted all the chemotherapy and biotherapy to that 20,000 population town. That meant over that 10 years, they had more resources from the government, more staff like registrars, residents, and also needed infrastructure. So that gave us some confidence that maybe we have to leverage the telemedicine technologies to build rural systems, not just seeing patients.
Thank you, Dr. Prakash, for your insight into this topic, and also to Professor Sabesan for his perspective from his practice in Australia. In part 2 of this podcast, we will explore how the difference between American and Australian healthcare systems impact care for rural patients, the need for advocacy from doctors, and a pilot project in Montana I'm working on with ASCO. I'm Dr. Hensold, and I would like to thank all of our listeners of Cancer Topics, ASCO Education Podcast. This is where we explore topics ranging from implementing new cancer treatments and improving patient care to oncologist well-being and professional development. If you have an idea for a topic or guest you'd like to hear on the show, please email us at education@asco.org. To stay up to date with the latest episodes and explore other educational content, visit education.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.